Welcome, welcome. We're going to get started. So, today's webinar is called Deep Dive into Breast Cancer Disparities. I am Megan Claire Chase, and I am Share's Breast Cancer Program Director and host of our BC Life podcast. Plus, I'm an 8-year invasive lobular breast cancer survivor. Now, before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, podcasts, and our helplines, please visit our website at sharecancersupport.org. So now I'd like to hand it over to Dr. McDonald to introduce herself. Dr. McDonald, the screen is yours.
Hello, thank you so much for being here today. I'm going to just jump right in because we have a lot to cover. Just as a brief overview, I am from Columbia University. I'm an associate professor at Columbia University in the field of epidemiology. I specialize in breast cancer epidemiology as someone who looks at how does breast cancer come about. What is the mechanisms that are important for us understanding how breast cancer comes about such that you can target breast cancer? Today, I'm going to take a deep dive into the area of breast cancer disparities. And to really understand how we as a nation understand disparities, it's really important that we understand some of the terminology. So bear with me as I kind of ground you in the concepts of disparities, and then also what is our nation's overview when it comes to breast cancer epidemiology. So this journey will consist of us defining the problem, understanding breast cancer, understanding how disparities arise, but not only how they arise, but why do they persist? And then looking at some approaches to reducing cancer health disparities. So first topic is epidemiology. Many of you already know what epidemiology is because of COVID-19. But specifically, I just want to ground everyone to understand that really, without epidemiology, we can't really understand health disparities because it's how the diseases affect the health and illness of populations versus primary care, which determines the individual. Epidemiology is about the illness within the population. And so it's the way we study and measure to really understand and address health disparities. Now, that's what epidemiology is. So, what is cancer? So, cancer pretty much is about a cell ensuring that it can live and be immortal without relying on any of the endogenous signals, endogenous mechanisms that a cell needs. So it becomes independent. It's able to have its own growth signals. It's able to create its own blood vessels. It's able to move. It's able to replicate itself. It's able to not apoptose, which is to actually burst open where the cell dies. And it's able to be insensitive to our endogenous immune systems signal to stop growth. So for the most part, it's like that independent child that goes off in the world and never comes back home. It's completely independent. And then one of the things that I really like about Siddhartha Mukherjee, who is a professor at Columbia University, he wrote The Emperor of All Maladies, which is a biography of cancer. And the phrase is, if we seek immortality, then so too, in a rather perverse sense, does the cancer cell. So that means that the cancer cell is trying to live forever. So now let's define disparities. So we've defined epidemiology, we've defined what cancer is. Now let's look at disparities. So disparities is really a measurement of difference. So cancer disparities are differences in cancer measures that could be the number of new cases that the nation sees in a year, the number of total cases that are in the US, the number of deaths in a year, screening, stage. So it's really looking at the whole population and understanding these measures across different populations. Now, cancer disparities can also be seen when outcomes are improving. For example, if you're seeing an improvement in mortality, but they're not shared with other groups. And then when we think about what those groups are, we often define groups by socio-demographic, so social characteristics, race, ethnicity, geographic location. As many of you mentioned, you're in different areas. So what we would do to understand cancer in your area would be looking at what is the cancer new cases in your geographic area. And then we'd say, okay, now what is it across these different other social groups? Or we'll say, like, okay, in your area compared to some other people's area, just to understand where are the differences, where are the disparities. But with all those definitions, we know that epidemiology is the study of disease. We know cancer. It's very straightforward. It does not know the definition of epidemiology. The goal of cancer is to persist. The goal of cancer is to be immortal. It is not defining who, when, how someone gets cancer. It has one goal. Then how is it that cancer is pretty much non-discriminatory, but disparities exist? So let's start with understanding what is breast cancer in globally and nationally to really understand how do cancer disparities arise. So globally, breast cancer is very one of the number one diagnosed cancers among women. And pretty much you see here that this is the number of females that are estimated to be diagnosed in a year. And then this is the estimate for those who are dying of the disease. And what you can see is that the darker color means the higher rate of those being diagnosed with breast cancer. And then the lighter color is the lower means that the rate of mortality or dying from the disease is lower. But if you see in parts of Africa, while rates are much lower than it is for the US, there's much higher mortality. For the US, while we have over about 287,000 new cases, the fact is we have lesser deaths than other nations, but it's still not acceptable. The quote you often hear about the US is that 1 in 8. So if you think about your network of people, 1 in 8 women will develop breast cancer in their lifetime. So when we think about breast cancer over time, because breast cancer is actually, they've seen breast cancer in mummified humans. So 3000 BC, they've seen cancer. We've been really tracking cancer nationally since like the 1970s. And so if we focus here on breast cancer epidemiology, this is the incidence, which is being diagnosed with breast cancer. And so in the dark blue, we have white, and in the light blue, we have black. And what's interesting is that even starting from the 1970s, we see that white women were more likely to be diagnosed with breast cancer and Black women were less likely. Now that we're looking at our current century, Black women have not really improved at all with the incidence or developing new cancers, but there has been improvement for white women. So now the difference that we used to see in the 1970s, where Black women had a less likelihood of being diagnosed, now that's pretty much gone. And Black and white women are diagnosed at pretty much almost the same rates. It's only 4% lower incidence. And here we're looking at the incidence across different races and ethnicity, because it's important that we understand that it's not just Black-white differences. It's the fact that Black women have health disparities compared to pretty much all races and ethnicities. So here we're looking at American Indian and Alaska Native, Asian Pacific Islander, and Hispanic. And the incidence being diagnosed is in the light pink. Dying from the disease is in the dark pink. And if you see Black, they have the highest rate of mortality, even though they have a lower incidence rate than white women. Now, if we see here, this is for everyone, but we also see there's a higher death rate for not just Black, but American Indian and Alaska Native, despite having a lower rate of being diagnosed with the disease. This is a true disparity. So, why? Like, how did that come about that white women were having higher rates, but yet now we're at equal rates? Like, how did that come about in history? Well, I love this phrase that came from an article that I read when I first started as a postdoc. And it was all about, like, how do health disparities arise? Well, they arise when there is something you can do. The moment you can't do anything, then everyone's in the same boat. Everyone's going to sink. If there's no treatment, then you get the disease, you die from the disease. Cancer's not going to discriminate at all. But the moment that there's something that humans can do, that medicine can do, that technology is what creates that's discrimination. So this is looking at in the blue, white women and the deaths from breast cancer over time. And this is the time period where there is not much you could do. In the 1940s, it wasn't until the introduction of the endocrine targeted trials in the 1970s, and then the actual implementation of these therapies into standard care in the 1980s, and the 1990s, sorry, that we start seeing these vast differences. So right here, everyone's in the same boat. 1980 comes about, everyone's pretty much in the same boat. There's clinical trials going on about the first endocrine targeted therapies for breast cancer, but it's not standard of care. So not everyone's getting it. But the moment you get to the point where the 1990s, which is here, that it's available, it's a technology that should be available to all, that's when the disparities start arising and they get steeper and greater. So before 1980s, Black women actually had a slightly lower mortality rate. It was pretty much the same. 1980s, rates were actually equal. But the moment we hit our current period, when there was technology to reduce the rate of death, that's when we started seeing these disparities. So when there is something you can do, health disparities arise. Now, when we're thinking about breast cancer, there are racial differences in mortality, where compared with their white peers, Black women are diagnosed at earlier ages, later stages, with more aggressive tumor subtypes and tumor features, less likely to receive stage appropriate treatment, have lower stage for stage, which means if you compare a white woman and Black woman at the same stage, Black women have a greater likelihood of dying compared to white women. And they also, when we think about survivorship, Black breast cancer survivors experience a higher burden of comorbidities. These are things like cardiovascular disease or diabetes, things that are not just cancer, but actually are comorbid on top of cancer. And they also experience a poor quality of life. So, what is going on? Like, why is this the case? Well, the fact of the matter is, a lot of people have suggested that, oh, well, these differences are just by subtype. It's just, that's all it is. Black women are more likely to get hormone receptor negative breast cancer, which means that you've heard of triple negative breast cancer, which means it's estrogen receptor negative, progesterone receptor negative, as well as HER2 new negative. But when we think about like hormone receptor negative, we're mainly talking about the main hormone receptor, estrogen. And so if we see here, there are differences in rates. So here is women that are white, and this is non-Hispanic Black. And then if we look at hormone receptor positive breast cancer, which is in the blue and the light blue, we see that, which is the most easiest to treat because there's a receptor that drugs can attach to. White women have a higher frequency of developing hormone receptor positive. But when we look at hormone receptor negative, and let's really focus on the purple, which is triple negative breast cancer, we see that there's far more triple negative breast cancer for Black women than there is for white women. Black women have a 65% higher rate of being diagnosed with hormone receptor negative and an 81% higher rate of being diagnosed with triple negative compared to white women. So we see that, but let me let you know, this is something where, is this a disparity or is this biology? Well, this is something where we are seeing these higher rates of aggressive tumor subtypes. But we also see the aggressive tumor subtypes in white women. So let's keep going to explore more of these differences. So Black women are known to be diagnosed with breast cancer at younger ages. But what we've seen over time, this is looking at age-specific breast cancer across ages. And this is specifically looking over time from 1976 to 2009, using a registry that accounts for many different cancers across our nation and is considered population level data. And what we see is that in this little blue box from ages 25 to under 45, there's this rise in the rates of breast cancer being diagnosed. Now, we think of breast cancer as a disease of older age. That's why the rates are so much higher at older ages. But there are young people now getting the disease. And what we see here is that this is the age at diagnosis. So between 1976 to 2009, every year, those who were aged 25 to 34, every year saw a 2% increased risk of developing breast cancer. So think about compound interest. So 2% every year from 1976 to 2009, there was an increase of young women being diagnosed. But the fact of the matter is that that differs by race and ethnicity. So while we're seeing overall an increase in early age onset breast cancer, the highest rates are among Black women who see a 3.5% increase compared to non-Hispanic white, which sees a 2.7%. They also looked at geographic, and they see that there's a higher rate being diagnosed within cities versus non-cities. So young onset breast cancer is on the rise, and Black women are once again experiencing the higher rates. Now, this is looking at, okay, well, there's different types of breast cancer. Like we said, we're looking at hormone receptor negative. We know that Black women have a higher frequency of developing that disease. But recent studies suggest that when we look from 2010 to 2016, and we look at luminal A and luminal B, and for simplicity, these are hormone receptor positive breast cancers. And they're asking the question, well, if we see that there's this increase in early age onset of breast cancer, women being diagnosed under the age of 45, and we see that there are higher rates in certain racial and ethnic groups, what is the subtype? Like, what are we really seeing? And so one would think it would be triple negative breast cancer, right? Because that's the cancer that's most commonly, that not commonly, but that is a higher diagnosis rate within Black women. But what they show is that in women 25 to 39, for those with hormone receptor positive, non-Hispanic Black women are experiencing increased rates of this subtype, hormone receptor positive, the breast cancer subtype that's the easier to treat. 40 to 54, we're seeing the same thing. Black women are experiencing an increase of being diagnosed with estrogen receptor positive. In fact, during this time period, triple negative breast cancer has stayed pretty much the same, if not a little bit declined for ages 40 to 54. So what we're seeing is that the rise in early age onset, it's really estrogen receptor positive, which is the easier to treat breast cancer, but yet we're still seeing differences. So this quote came out of the American Cancer Society, and it's annually they look at breast cancer death rates, and specifically across the nation. And they have an entire booklet that really explores cancer in Black individuals. And they said, we have been reporting the same disparity year after year for a decade. Breast cancer rates are highest for Black women again. The differences in death rates, with all the differences I just showed you, with all the difference in biology of like who gets hormone receptor negative, age at onset, the differences in death rates are not explained by Black women having more aggressive cancers. It is time for health systems to take a hard look of how they are caring differently for Black women. So despite me showing you all of those differences in how breast cancer presents, cancer is cancer. It's non-discriminatory. It's trying to survive. It's trying to live. Some cancers are more aggressive than others, yes. But the fact of the matter is that the mortality that we see is not because Black women have more aggressive cancers. It's not because Black women are diagnosed at later stages. It's not because Black women are diagnosed at younger ages. And then this just kind of shows you looking at survival by subtypes. Like I mentioned here, this is looking at 5-year survival rates by stage at diagnosis. And this is for all subtypes. So hormone receptor positive, hormone receptor negative. And what this shows you is that if we look at localized, so catching it early, it's not metastasized, you're catching it early. We see here that white women, almost nearly 100%, are more likely to live for 5 years once being diagnosed. But for Black women, it's below everyone else. It's 96. If we look at regional, saying it's in the breast still, but it's not at the site that it first developed. We see that once again, Black women have lower mortality rate than everybody, a higher mortality rate than everybody, less survival. And the trend goes on. And then when it's unstaged, that's kind of one of those things, like it may be the time where like there's just nothing you can do. But the fact of the matter is, across every single stage, comparing apples to apples, Black women still have a lower survival. So, what is going on? Why do these disparities exist? Not only why do they exist, but why have they persisted time after time and year after year, again and again? So now I'm going to show you some information from this amazing report. It's from the American Association for Cancer Research, and it's their Cancer Progress Report that just came out this year. And it's titled Understanding and Addressing Drivers of Cancer Disparities. And part of that document, they have this great figure that really goes into disparities that are experienced in the cancer care continuum. But not only that, it talks about drivers of health that are related to culture, behavior, the environment you live in, psychosocial, clinical, but that's also influenced by racism, discrimination, segregation, structural inequities, social, societal injustices. So you start here, living your life, being oppressed or suppressed by these factors, which may impact how much money you make or where you live or your ability to run outside and have walking or doing exercise. And then you develop cancer. But in developing cancer, now you also have disparities in early detection, the treatment, and the survivorship, which all leads to adverse health outcomes. So these are just the categories that we'll go through. Because you all will have access to the recording, I try to make sure that while there's going to be a lot of detail on the slides about the AACR Cancer Progress Report, I'm not going to go into every single textual fact, but this is why cancer disparities persist. Yes, it started because there was something we could do about it. There was a drug that was standard of care. But why does it keep occurring? Well, let's talk about the social determinant of health, also known as SDOH, socioeconomic status. 44% higher mortality. What is that referring to? Women diagnosed with breast cancer, this is talking about geographic, during 2007 to 2016 at a Florida cancer center, who were living in the most disadvantageous neighborhoods, had 44% higher mortality from breast cancer compared to those living in the most advantaged neighborhoods. So just socioeconomic status alone played a role in surviving being diagnosed with breast cancer. And this is looking at some other key social drivers like living under poverty, healthcare status, food insecurity, crowded households, educational attainment. And really what they're trying to showcase is the percentage of individuals that are living under these circumstances. In 2022, while about 9.5% of white were living under poverty, 17% for Black and Hispanic were living in poverty. When we think about healthcare status and we think about uninsured adults, while 7% of white are uninsured, it's 19% and 21% for Hispanic and American Indian, Alaskan Native, respectively. And so forth and so on and so on. So when you're living amongst these social drivers, there is going to be a biological component as well as a access component when you're diagnosed or when you develop and when you're diagnosed with cancer. Now, there's also access to healthcare. Now, this is based off of health insurance coverage. This is looking at inequities in healthcare systems and services, and it goes through affordability, availability, accessibility, the accommodations that you receive as a patient, and the acceptability, the quality of care that's provided to you, regardless of your personal attributes, such as race. So if we look at this is looking at the social determinant of health, SDOH, access to healthcare. And this is looking at the delay or the non-receipt of needed, not optional, needed medical care. And what we see is that the uninsured, this is like needed medical care. So there was a delay for those uninsured, not being up to date with colorectal cancer screening, which is universal. Not insured, 78% are not up to date. And then breast cancer screening, 70% of those who are uninsured are not up to date. So, and these are things where this screening, catching disease early, helps with survivability. But the fact of the matter is being uninsured, or even in this case, having Medicaid or other public makes you have a less likelihood of being up to date with your screening, as well as having a delay is mainly for uninsured. So now let's talk about biological factors and genetics. So I really wanted to focus on this because many people will say, oh, cancer is all genetics. The fact of the matter is that cancer is genetic. It absolutely 100% is. It's not all genetics. And what you have to understand is that there is not one gene that is deterministic to developing cancer. Not even BRCA1 or BRCA2, the breast cancer genes, even they do not 100% guarantee that you develop cancer. Sorry, I still have a house phone. So when we're thinking about the biological factors, it's really important that, yes, it is genetic, but it's not the only. Some things that we see when it comes to social determinants of health and biology and genetics is that we see that African American women, as I said before, have higher rates of higher frequencies of triple negative breast cancer, but they also have quadruple negative breast cancer, which is having the lack of an androgen receptor as well. And these women who are diagnosed with triple negative breast cancer are more likely to also biologically have quadruple negative breast cancer. And it's likely to be earlier onset. So in this way, we're thinking about the biology. If we know that Black women have a higher frequency of TNBC, and we know that those with TNBC are more likely to also have quadruple negative, and we know that that type of cancer is associated with being diagnosed at an earlier age, then biologically that makes sense, right? That's why that's the social determinant of health related to the biology of the cancer you develop. We also look at tumor characteristics and the difference in hormone receptors, but these are also influenced by social determinants, by socioeconomic status, by environmental conditions. When we think of evolution, that also plays a role as it relates to the type of genetics that one has based off of the evolutionary influence. So this is important mainly because of the concept of precision oncology or precision medicine, which is the right treatment at the right time for the right person. And when we have clinical trials, the whole purpose of clinical trials is to develop a drug that would fit the individual with a disease. But now with genetics, it's really to develop a drug that is specific to the genetic composition of that person's disease. Now, from preclinical, which is mouse studies, that's just really understanding the concept of the drug. But once we move into human populations from phase 1 through phase 3 to look at the safety, the dosing, as well as the efficacy of the drug, historically, Black people are not included. Black women, Black men are not included in these trials. So by the time we get to actually rolling that drug out, we are in the queue to get the drug, but we were never in the development of that drug. And so this is looking at, I found very interesting, the participants in trials supported by NIH, National Institute of Health, Centers and Institutes. Tax dollars pay for the National Institute of Health research and clinical trials. And so if we see here, I'm just going to go here with Black African American. In 2013, we had 12.2%. And in 2018, only 13.5%. But yet in whites, we have 52.9% and we moved up to 60%. Something's not adding up. And then this is all NIH institutes. Now let's just focus on the National Cancer Institute, NCI, where all of the cancer research takes place that's by the government, that I get funded for to do my research as an external investigator. If we look at the share of Black participants in clinical trials by NIH institutes, and this orange right here is the NCI, we see that for Black participants, it barely ever goes, if at all goes, above 10%. There's a problem, because if we're not represented here, but we're given the drug here, and post-marketing says the drug is safe and effective, then we have all of these people that don't have the genes that the drugs were developed for. So while the drug was developed for this person's gene, where predominantly they're of European descent within these clinical trials, what do we do? What do Black men and women do? So it's the right treatment at the right time for the right person, kinda, when it comes to persons of color. Now, one thing is really important to know is that they're trying to move away from race as a proxy for a biological attribute. The new framework for looking at population descriptors and genomics is looking at ancestry, looking at human genetic variation. So making sure you include enough diversity within your clinical trials so you're getting a diverse amount of genetic diversity, which is what we need to make sure we're developing drugs that work for everyone. And when we think about ancestry, it's quite important. This is looking at specifically lung cancer. And when we look at lung cancer, they're looking specifically at EGFR gene because it's commonly mutated in lung cancer. So this is what is used to target lung cancer patients. So since EGFR is a gene that's commonly mutated, drugs target EGFR. But if you look at ancestry, Africans only have, in Africa, we only see 10% of EGFR mutations. Whereas if we look at Peru, it's at 51%, or East Asia, it's at 50%. So the fact of the matter, this is all based off of ancestry of where you you migrated to, where you were taken, where you evolved to. And this just showcases that while we focus on EGFR as a target for molecular therapy for lung cancer, for those of African descent, this may not even be helpful, with only 10% having this mutation. And that brings me to Dr. Melissa Davis's work, who is now at Morehouse School of Medicine, where she has gotten a $25 million award to really understand the societal, the ancestral, the molecular, and the biological analyses of these inequalities that relate to cancer. And so it's called SAMBI, and it's going to generate a database that looks at all of these measurements, not in silo, but together to really understand the cause and the influence of disparate cancer outcomes in underserved populations of African descent. And this is going to take place globally, such that there's going to be populations of African descent all around the world. Now, let's talk about the social and built environment. We also know that historically, structural racism is also associated with how one develops and how one survives breast cancer. This is looking at redlining, which is where historically those who were allowed to live in certain areas that were more prominent versus not. And what was very interesting about this study is that this is looking at white women here, and this is those living in the best versus the most hazardous. And if you look here, you see that, all right, so living in the best neighborhood versus the most hazardous, this 0.34 is protective. So white women who were living in areas of structural racism fare better. They're less likely to have late stage, less likely to have high grade tumors, less likely to get triple negative breast cancer, less likely to die. Even when we look at still desirable versus hazardous, so still looking at like not living in the best neighborhoods, they still fare better. If we look at definitely declining versus hazardous, it's marginal, but they're still doing better. White women are doing better in areas of historical structural racism as it relates to breast cancer, even than Black women. And this is also looking at persistent mortgage discrimination. And it was found that when you look at non-Hispanic Black women, higher mortality rates were seen regardless of where they lived, regardless. Whereas for non-Hispanic white women, it was 2.2 times more likely that they die of breast cancer in areas with persistent mortgage discrimination. So in this case, if they were living in a worse environment, white women fared worse. But Black women fared worse no matter where they lived. And there's also stress, because stress is associated with inflammation, which is a marker for greater cancer risk. We also know there's modifiable risk factors like exercising. But if you are trying to do the best that you can and have and abide by these modifiable behaviors, like eat a high fiber diet, not smoking, the fact is that racial and ethnic minority populations live in crowded spaces. And compared to white individuals, there's a greater proportion of those belonging to these groups, and it can actually increase their exposure to cancer risk because of secondhand smoke. Now, there's a lot that people are doing around environmental exposures, and I've talked previously about, there's air pollution, there's water pollution. I've talked about the environmental injustice of beauty and the fact of being overburdened by chemical exposures based off of your beauty practices and your hair practices. But lastly, there is hope. All the things I just said that are coming from the American Association Cancer Research Progress Report. These approaches are being developed and are actually in action to address the drivers of health and reduce cancer disparities. And they're within the realm of three-pronged approach: policy, community, and research. Now, I'm not going to go into each different prong, but the fact of the matter is that each prong, from policy, like Healthy People 2030 and the Affordable Care Act, to the community, making sure we have patient navigation and programs that empower patients to make healthier choices, and the research, where we're looking at a multi-ethnic cohort, or we're making sure we're expanding clinical trials to be in underserved communities so that they're not commuting too far to be in a clinical trial. All of this is very important in us reducing the burden of preventable cancer. And when we think about this is the panel of people who, and there's many others who are involved in this progress report. But I encourage you to look at this progress report because it really does impact our understanding of the biology. How does the biology play a role? How do social drivers of health play a role? And how do the structural drivers play a role in understanding, but not just understanding, but addressing to mitigate cancer health disparities? Thank you.
Woo! Wow, Dr. McDonald. Um, um, I want us to get right into some questions here. And stellar presentation. So in depth. I'd love to ask you, like, one of our questions is this statistic worldwide, or is it a United States statistic? Black women have a 40% higher mortality rate from breast cancer than white women.
So that statistic is specific for the US, where they have like a 4% reduced risk of being diagnosed, but a 40% greater likelihood of dying. And that's for the US because every nation has its own. Like if you go to Europe, some European countries, you're not even allowed to take race into consideration. You can't use black, white. And then if you go to Africa, what you'll see, like in Ghana, they'll see it's more geographical. So you'll see urban communities versus the suburban or the farm communities. The urban communities have higher rates. So it really depends on regional, but that statistic is specific for the United States.
Okay. We have this one. It says Latinas are also disproportionately impacted by incidence and mortality. Classifying us as white denies the precise data needed. What are your thoughts on that?
Yes, so when they say non-Hispanic, Latinx, that is mainly including not the European Spaniard nations. So it's not including Spain. It's because that is true. Spain goes on how the census goes as white. But if you are from Puerto Rico or the Dominican Republic, a non-European Spanish nation, then you fall into Hispanic by the census. Now, what I've experienced doing my research in Washington Heights is that many don't define themselves as a race. So when you have a choice, some Dominican women will say that they are Hispanic, but they will not put a race. And that does create challenges when we're thinking about how we're aggregating this data. How are we analyzing this data? Where are our Latina women? And
Mm.
so what we've trying to move towards is intersectional identities where you can have more than one race. You can have more than one ethnicity such that you're not pigeonholing people. But I say that that's a very hard thing to do on a national basis because, like I said, epidemiology is for the population, and how you identify is where the resources go. So that creates a challenge. But I definitely hear what you're saying, and it's very true. I mean, unfortunately, even when I have to submit information to the National Cancer Institute for my study, I have to say unidentified for those Hispanic women who refuse to report their race.
So if they selected, or is that why we now have those selections of multiracial or biracial or
Mhm. Yeah, but they're not as you can be multiracial and be so many different things,
right,
right? So really the multiracial is great, but nationally we need to understand where do the resources need to go. And so that may be by location, that may be by race, it may be by multiracial. But that's what epidemia is about. They're trying to define you to figure out where the resources need to go. But the defining of people has never been a good thing in our nation.
right, right. I want to make sure I definitely get to this question. So, at Share, we have a lot of patient advocates, and for those patient advocates who are white, um, what are let's see, what efforts um, can they do to help encourage when they're talking to someone of the Black community or Hispanic Latin community? What are some things that they can do to help encourage them to enroll in a clinical trial if someone, who looks like them is not available?
Yeah, so and that's the challenge, because you really want to know somebody who has been through it, that they understand your culture. What I would say is listen. Listen to where their hesitancy is coming from. That's the first step. If their hesitancy is based off of culture, then it is your duty to say, okay, well, there is shared Latina that I can connect you with. Or, all right, I understand that. Let me connect you with this person at this hospital or this other person. Maybe it's travel. Maybe it's like I can't travel all the way there. Well, then you can address that because that's not dealing with race or ethnicity whatsoever. So the first thing to me to like get that cultural divide is to listen to where the hesitancy comes from and try to connect them with that person or that resource to mitigate that hesitancy.
Ooh, I like that. Ooh, I like that. Um, yes, I have this question as well. Can you explain what quadruple negative breast cancer is again? That I honestly I wrote that down as well. I was like, I have never heard that.
Yes. So Clayton Yates from Tuskegee University, who's now at Hopkins, looked at the androgen receptor. So when we think these are all hormone receptors, estrogen, progesterone, HER2 new, Herceptin, and androgen. We've really just looked at the three. First, we just looked at estrogen. Are you estrogen receptor positive or negative? And that was it. Then we started looking at estrogen receptor positive, progesterone receptor, and then that's where we got the luminal A, luminal B, and some other things. And then we learned about Herceptin, which was great because that's how we got the drug. So HER2 new used to be a very aggressive, non-surviving disease, but now we have Herceptin. So in your clinic, when you go to get diagnosed, you'll have those three in the United States. It's not
Mhm.
everywhere. You'll have those three. You will not be assessed for androgen receptor. But what has been found in research is that those who are lacking the estrogen receptor, the HER2/neu receptor, the progesterone receptor, are also lacking the androgen receptor.
Okay.
And it is more likely that when you're missing all four, you're going to be diagnosed at earlier ages. So Black women are more likely, no, Black women have a higher rate of being diagnosed with triple negative breast cancer. Ding. Those biologically with triple negative breast cancer are more likely to be quadruple negative breast cancer. Ding. Those with quadruple negative breast cancer are more likely to be diagnosed at earlier ages, which all aligns with Black women. Because Black women are diagnosed more frequently with triple negative breast cancer, and they're diagnosed more frequently at younger ages. So that's a biological, but you will not get tested for the androgen receptor in the clinic. It's not standard of care.
Okay, goodness. We're getting close to time, but I want to ask just another few questions here. So, let's see. I think you covered that. So what single change do you think can make the biggest difference in closing the disparities in survival outcome gap? Like what is a single change that could occur?
Racism, but I mean, that's very big. So what I think needs to be put in place is structural policies that that automatically preclude the ability for you to have racial or discriminatory acts when it comes to screening, treatment, survivalhood. And then like clinical trials, like there should be more outreach into clinical trials because no one organization decides who can be in a clinical trial. It could be Pfizer saying, hey, Columbia, I'm going to pay you to do a clinical trial. Here's what you have to do. It needs to be diverse. But Columbia then should go into the community.
Right.
Maybe the clinical trial needs to be in the community hospitals and not at the medical center.
Mm-hmm.
So there's not an organization that decides. It's the people who are conducting the principal investigator of the clinical trial, and the protocol that they follow is what designates who gets in, like who they're approaching. And then there's other things like sometimes like what has been is that comorbidities like high blood pressure, diabetes, that can exclude you from a trial. And oftentimes that excluded those who were from marginalized communities. So we need to also stop restricting, and we need to be inclusive. We need to stop saying male, female, like those with a uterus, those with a prostate, and such that people feel welcomed and comfortable coming into a clinical trial. So I think it's across the whole continuum, but it's really going to take some systemic and structural policies such that it's an expectation and a rule and not just a nice thing to do.
Right. And really meeting the people that you're trying to reach, meeting them where they are and
Yes.
working with them. Okay, so we are actually a little over here. I'll send you the rest of these questions. Everyone, we were just getting lots and lots of questions here, so I'll make sure that those get answered. Dr. McDonald, I just want to thank you on behalf of everyone here attending today and who will ultimately listen to the recording. Thank you so much for your time, your expertise, the patient-friendly way you explained things. Thank you so much. This was so in-depth. Everyone, I just have one more question. What are like the biggest takeaways for patients with this presentation? What do you want them to take away here today?
I want you to take away that, breast cancer survivorship is something that you will see disparities in. But these disparities, now that you see them and you know them, you can look out for them. So when you're getting clinical care or getting medication or interested in a clinical trial, make sure you're expressing your voice and not just taking things status quo, because these disparities do exist even at the survivorship phase. So being like knowledgeable and holding that, and then fight for your equity and getting what you need.
Thank you so, so much. Also, make sure to check out Share's website for upcoming educational programs, podcast episodes, and support groups. And don't forget to follow us on social media as well. And please take a moment to complete our survey that's at the end of our webinar. The survey will pop up in the browser when we end the webinar. And the link will also be sent in our follow-up email as well. And all surveys are anonymous. Everyone, this concludes our presentation, and thank you again, Dr. McDonald. You're amazing, and I hope everyone has a great rest of your day and week. Thank you.
Bye.
Bye-bye.